Thank all you guys for wanting to listen to me talk today about sarcopenia. About a month or so ago, Dr. Rogers came up to me and she asked me, would you be willing to talk about sarcopenia in front of this group of people? And I said, of course, I love sarcopenia. I could talk about this for hours. Don't you guys love sarcopenia? How many of you guys know what sarcopenia is? Not you three. No, put your hand down. Know it all. Okay, so if we're going to talk about sarcopenia, we should probably give ourselves some degree of a framework on what it actually means. And what it really boils down to is how we go about treating people. When we as caregivers are talking with patients and their families and trying to come up with a treatment plan, what we're doing is in our minds, we're assessing the relative risk and the relative benefit for any given type of treatment we have. So if you can imagine the scales of justice balancing in our heads, in this situation, the benefits appear to outweigh the risks. And if that's the case, then we should probably recommend going whatever treatment we're talking about, whether that be surgery, chemotherapy, radiation therapy. It could be talking about starting a blood pressure medication or treating your diabetes. The same thing should apply in all throughout medicine. However, if the scales tip the other way, if the risks appear to outweigh the benefits, then we're probably dealing with something where we probably shouldn't be doing whatever type of therapy that we're proposing in that situation. So as we go through this, really what we're talking about are what are the relative, when we're talking about benefits and we're talking about risks, what we're talking about is, are we going to improve how long a patient lives? Or are we going to improve the quality of the life that they have? As Dr. Hesen always says, are we going to cure them, make them live longer, or make them live better? And really that's what we're asking ourselves as we go through this. Now, there's a lot of research and a lot of data talking about the benefits of any type of therapy. If we give chemotherapy X, if we do surgery Y, if we do whatever intervention, we know we can improve people in some way or the other. What we're really going to talk about today with sarcopenia and frailty is the relative risks that we're approaching to patients and how we can go about measuring those risks so that we can give a more informed conversation with patients and also ways that we can try to improve those risks. So historically, when we talk about risk, what we're talking about is people come up with various ideas of how you calculate risk. And there are decades worth of research which supports these data. And everybody in here knows the elderly patient does worse than the younger patient. Everybody here knows that somebody who's got other medical problems like diabetes or high blood pressure or coronary artery disease, they do worse than people who are healthier and don't have those problems. And I think many of us also know that the complexity of the treatment that we're going to offer or the complexity of the cancer that a patient has will also affect the outcome that they're going to have. For example, if you're coming in, even if you're an unhealthy individual, and you have a skin cancer, it's going to be taken off your forearm with local anesthesia, you're probably going to have a much better outcome than a healthy person who's got to come and have a major GI operation with associated chemotherapy and radiation therapy for pancreatic cancer, Ms. Clements, or for colon cancer, or for other types of major cancers. And so what people have tried to do is to try to come up with algorithms using numbers and checkboxes to try to figure out the best way to analyze these risks. And so as surgeons, the American College of Surgeons, developed this risk calculator. It's called the National Surgical Quality Improvement Project Risk Calculator. It's available on Google. Type it in, you'll find it up real quick. What it basically does is it takes into account not only the type of procedure that a patient's going to undergo, but also all the various risk factors we talked about. How old they are, whether they have any of these comorbid conditions like diabetes or high blood pressure, if they smoke, how big they are. They type it all into a computer, and at the end it spits out a number and it tells you there is a X percentage chance that you're going to have a complication with this operation, or there's your expected length of stay after this operation is 5 days versus 3 days for a healthier person. And that's great. We can take all these numbers and chew them in together and come up with these complex calculations and algorithms. But at the end of the day, we're not just a bunch of numbers that we stick on a barcode in the back of our necks that we can plug in together. We are individuals, and we all have our own individual quirks and idiosyncrasies that help figure out how we're going to do. So kind of using that as a background of what we need to talk about, we're going to move on to frailty. And this concept of frailty has been around literally forever. Everyone's heard the phrase, oh, that person's frail, that person's robust. And so frailty has been around for a long time. It's an ambiguous term. And people used it for a number of different reasons. I'm going to pick on my father a lot. Julie knows why I do this, but I'm going to pick on my father a lot. My dad will have moments where he's very, very frail, and he'll have his moments where he's perfectly robust. He's actually a very healthy gentleman. It is largely described as a symptom of older age, and since cancer is a problem that really develops over age, over time, it's an attractive way to look at how we assess cancer-related risk. And it wasn't really until the late 80s that a gerontologist named Linda Fried at Johns Hopkins really started conceptualizing the definition of frailty and really organizing it so that it makes more sense to the average person. And so what she did was she looked at the various clinical formats that come with frailty and also the genetic changes that are associated with frailty. And we're not going to go into all those details. I don't want to lecture you guys for hours on end on sarcopenia and frailty. Frailty as a symptom of age is the first thing that I always challenge. You can have people that are elderly that are frail, that have to have a walker, that have to have people help them around, like my dad when he has a bad day. And you got people who are not frail that are elderly. This guy actually looks downright angry given the amount of work he's probably put in the gym. So Fried basically broke frailty down and said that it's basically that she was able to calculate as a way to measure or estimate the risk of a catastrophic event occurring as you had a decline in physical and health status. And she broke it down into a constellation of series of symptoms, which I got up here. And these have been largely used over and over in various different assessments of frailty, but they are things like how weak you are, how slow you are, do you have reduced activity, low energy, weight loss? But she still focused it on as being a disorder of age. And frankly, that's something that, as a cancer doctor, I quibble with all the time, because people can be frail at all ages. A young person can be frail, an older person can be frail. It's not a disorder of age. Dr. Fried's approach has been largely adopted across different types of studies, but for the most part, the exact criteria and particular measurements may vary from study to study. And this is one of those types of measurements. It's called a modified frailty index. I'm not going to go through it each one by one, but you can see it. It involves things like asking what the overall functional status is. Are you partially or totally dependent? Do you have diabetes? Do you have congestive heart failure or lung disease? And it focuses heavily on various vascular ailments, whether or not you've had a stroke, whether or not you have high blood pressure, whether or not you've had to have some sort of bypass operation or amputation because of decreased blood flow to your extremities. And if you type into PubMed or Google right now, frailty and cancer, you're going to get probably several 100,000 different studies. This is one of the more later ones that was published, and so it just shows you what you can identify. This is a study using the NISQIP data set. So this is across the country over the course of about 10 years or so. It's looking at about 42,000 people across the country who had surgery for various types of GI cancers. And people who were defined as being frail had a longer length of stay, they were more likely to have a complication, and they were roughly twice as more likely to die from their operation. So frailty is obviously very, very important, and it seems to be something that can be reproducibly used to predict how people are going to do. But there are some problems with frailty. First of all, the variables are very subjective. Picking on Dad. Is he partially or totally independent? There was a day a few months ago where he fell in the shower and hit his head, and he had to have a few days where he had to have people walking around with him. He was partially independent during that time period. Right now, Pop is out there running. He runs about 3 or 4 miles a day in the neighborhood every day. Impaired sensorium. Oh, I could have fun with Dad on this one. The other day he called me up, and I don't have a Facebook page, but he called me up and asked me, he goes, "Hey, I saw your Facebook page." I said, "Dad, I don't have a Facebook page." And this went back and forth, you can imagine, for about 5 minutes. And he eventually sent me the link for the Facebook page. And I typed it in, and I looked at it, and I said, "Dad, do you not know who your son even looks like?" Some of the variables that we go into these these arguments don't account for the severity of disease. Dad's got single drug hypertension. He takes one drug that, when he does a good job with his diet and exercise, he can come off that drug. But I've got somebody on my service right now who's taking 5 different medications for her high blood pressure. Is it fair to say that both of them have high blood pressure when clearly Dad is in better shape? There are different ways to measure things like diabetes. There's some people who have diabetes and they're taking one medication, or at worst, are just controlling their blood sugar by not eating a popsicle after dinner. And there are others that are taking a dozen different medications and hundreds of units of insulin. And so these types of calculators don't always take those into account. And finally, as I mentioned before, frailty is considered a disorder of age. And that's not exactly fair. Younger people get cancer, younger people can be frail. And so we move from frailty then to other ways to describe frailty. And so what we're going to talk about, and the title of this thing is Sarcopenia and Cancer. So what is sarcopenia? And sarcopenia basically means that you've lost muscle mass. And this was described by a researcher at the University of New Mexico who basically did a population study of the people in New Mexico. And what he found were that of people over the age of 80, over half of those people had lost muscle mass and were described as being sarcopenic. And the way he described sarcopenia was he used complex algorithms to measure the muscle mass using x-rays and comparing it to other matched healthy normal people of younger age. But he found that people under the age of 70, about a quarter of them could also be considered sarcopenic. And so there are very, very well-defined definitions of sarcopenia now. And this is a European working group whose entire job is to define sarcopenia. These guys have a great job, right? They meet once a year and talk about this. And what they talk about is that you have low muscle mass as defined by being less than 2 standard deviations below the mean of a matched younger person. I'm kind of going through this not because I expect you all to remember it, but because of how ridiculously silly this is. They also talk about low gait speed. In other words, how fast does it take you to walk a certain distance, or low grip strength. Those little squeezy things that you get at the gym? They basically measure those to see how well your strength is. Muscle wasting is inevitable as we age. And so this is something that can be applied to younger people as well as older people. We have exceptions to the rule, but most of our favorite athletes, after they get to be about 30, 32 years old, they start to tail off. Now, I know Tom Brady won the Super Bowl this year, whether you like him or not. But we see decline, the functional decline in our athletes, even the healthy of us when we get past age 30 or so. This idea of sarcopenia is multifactorial. It's not just due to diet and exercise. There's more to it than that. And then that's something that I'm not going to really delve into right here, mainly because we don't understand that well. And unhealthy people, even at young age, can have sarcopenia. So this is something I just grabbed off the internet yesterday. This is a woman who I think is in her late teens in Australia who became anorexic because of a variety of psychological issues she was going through, bullying and depression and the like. And you can see she's starting off here in a relatively healthy, normal weight, and she progresses to here and eventually there by being bulimic. Now this woman is, I think, 18 years old at the time these pictures were taken. She's clearly frail, she's clearly sarcopenic, and she's clearly unhealthy. So this is something that can be applied to older people, as we've previously described, but it can also apply to younger people and have a much more meaningful impact in that regard. So how else can we measure sarcopenia besides all those fancy measurements? And I bet all of y'all know what this is. It looks like a Rorschach ink blot test. There's Batman over there. So this is the way we measure sarcopenia nowadays is we try to utilize something called the psoas muscle. This is a large muscle in our back. It's an involuntary muscle that helps us keep ourselves upright. And we can actually measure this on a CT scan. These are 2 CT scans of patients I'm going to operate upon this week. One was this morning and the other one's on Friday. And we can actually encircle out their psoas muscles right here and measure just how big and bulky their muscles are or not. And as you can see, the person over here on the left has a much bigger and much bulkier psoas muscle than the person on the right. And so we can use this now to try to, as a functional measurement, to figure out how people are going to do with both surgery and with cancer. And the first person to really do this is one of my best friends. I get my fellowship with him. His name is Peter Peng. He's a surgeon in California. I was telling Rogers he's obsessed with buying real estate out here in the Birmingham area, and he's trying to get me into it. But what Peter and I did was we sat down together and we basically measured psoas muscle measurements to predict who had sarcopenia and who did not for a series of different types of patients. And these are patients who have colon cancer and are undergoing liver surgery for metastatic colon cancer. And the people who were sarcopenic had worse outcomes. So they were more likely to have longer hospital stays. They were roughly 3.5 times more likely to have a major complication. And the thing that both of us noticed was that if you were both sarcopenic, you had low muscle mass, and you were obese, you were 5 times more likely to have a complication after this type of an operation. We extended that argument to people with pancreatic cancer, and so we divided patients into those that were sarcopenic and those that were not. This is a Kaplan-Meier survival curve. For those of you who don't really follow these type of graphs, what this does is it predicts the number of people that are alive at a given point in time after undergoing a diagnosis. So if I were to take an arbitrary data point of roughly 2 years, 24 months, you can see those patients who were sarcopenic had a roughly 50% survival. So roughly half of them were alive at 24 months who were not sarcopenic. By contrast, those that actually were sarcopenic, that number was literally in half, about 50% difference. So you can see that sarcopenia, muscle wasting, not only makes a big difference not in terms of the way you do after an intervention like surgery, but also affects how you do long term, even after you recover from your operation in relation to your cancer. So what are the pros and cons of this sarcopenia measurement? And this is when I first came here to UAB. And so the pros are, it's a very quantitative measurement. It's reproducible. I mean, it's a number. I can trace out these muscles and I can generate a number and I can look at that number. The drawbacks is that it's time consuming. I have to trace out those muscles. And one of my residents just recently did this, and we'll talk about some of her research in a second. And it took her like 6 months to go through about 300 patients, give or take. And the other thing about it is it's really not taking into account obesity as well. Let's face it, you got two people. The obese person is going to have a larger muscle mass just because he's got to be able to support that increased body weight. The thinner person, although healthier, will likely have a smaller muscle mass because he doesn't require that. And so when I first got here, Dr. Heslin pulled me aside and said, I got an idea. He goes, and I can't do a Heslin impersonation, sorry Marty, but I can't do a good one, sorry. So he said, can we measure, because there's an easier way that we can measure functional status. So he came up with this idea. He said, what if we just walk up and down a flight of stairs? So we have people go, they walk down a flight of stairs, and they walk right back up, and we measure how long it takes them to do it. And can we use that as a surrogate for all these other measurements of frailty and sarcopenia? And so what we wanted to know is, can we actually produce a stress on these patients by making them do that? A stress that would be something that we can reproduce with cancer or with surgery or chemotherapy. Does it predict the outcome? And does it predict outcome? Does it actually predict the way people are going to do after they have an operation? Next slide's a little busy, sorry, but we'll just but it's a graph, and so it's easier to follow. These were the measurements of people's vital signs. So we asked people to walk up and down a flight of stairs before they had a major operation. And we categorized them based on how long it took them to walk up and down the flight of stairs. So the people over here on the left did it faster. The people on the right did it slower. This is one flight of stairs. I did it in my wingtips right before we did this study. It took me about 6 seconds, so it's not a terribly difficult task. But as you can see, some people, it takes them up to 25, 30 seconds. Some people couldn't pull it off. And what you can see is that as you put people through stress, as you get on the treadmill, as you walk up and down a flight of stairs, your heart rate and blood pressure go up. The people who did it very quickly, it didn't produce as much stress on them. They only had a slight 5 to 10% jump in their heart rate and blood pressure. By contrast, the people who took a long time to do it, they got upwards of a 15 to 20% increase bump in their heart rate and their blood pressure. So we were clearly able to induce some degree of stress by making them walk up and down a flight of stairs. So the next question was, does that actually help predict outcome? And I'm not going to show all the data slides from this study and all in this paper, but here's one of them. The people who took less than 15 seconds to walk up and down a flight of stairs had a less than 5% chance of having a major surgical complication. And these were all people who had cancer in our practice, Marty's, mine, and a few of our colleagues. The people who took greater than 25 seconds to do the same task had over a 50% complication risk. So clearly we were able to demonstrate using this idea that walking up and down a flight of stairs is a good means to predict how people are going to do. Is it as good as the other means that people talk about? This was one of the questions that we were asked when we were up there. They're like, well, how does it do when compared to these other types of measurements? And so, And so additionally, the people who took a longer time to walk up and down a flight of stairs, not only did they have an increased complication rate, but they stayed in the hospital longer, 3 extra days compared to those who were able to do it very quickly. So does this compute with other types of calculators, other types of algorithms? And so another busy slide. This is the work of one of our residents, Samantha Baker. What she did was she said, well, how does this relate to the sarcopenia measurements that we've been traditionally using by measuring psoas muscle measurements? So she spent the next 6 months going through 300 patient CT scans, measuring psoas muscle measurements. And what she found was that the people who took a short amount of time to climb the flight of stairs had big, bulky psoas muscles. The people who took a long time to do it had tiny little wimpy muscles. And at the same time, you saw an increased rate of complications. So our conclusion as we came through that was that maybe our measurements are just as good as the sarcopenia measurements that other people have been producing. And that's something that we're trying to focus on right now. But what it actually came out was that our measurements were actually better than sarcopenia. That the people that walking up and down a flight of stairs, as simple and as basic a task as that is, was associated with a better predictor of how people did after major abdominal surgery for cancers. And why is that? And why do you guys think that is? And I got it up here, but this probably takes more into account, because we're actually measuring function and not just body muscle mass, if you will. And I go back to my original diagram right here. You got the obese guy and you got the thin guy. This was something that we had noticed back in Baltimore. The obese person, I'm really trying myself hard not to use the F word right there. The obese person probably has a larger muscle, but he also carries a lot more jelly in the belly. Whereas the thin person probably doesn't need to have as large a muscle in that situation, and they probably have a better outcome as a result. So we've talked a little bit about what frailty is. We've talked about different ways to measure frailty, the importance of frailty, sarcopenia, functional status. What we really haven't talked about right now is how can we make this better? So cancer promotes sarcopenia, and there are a number of reasons why it does it. And some of it is the hormones that cancers make. They make us so that we don't want to eat. They make it so that we lose weight. Cancer, my patients love to ask me, what is a cancer? And I basically tell them it's a tumor. And tumors grow. And in order to grow, they need food. But how does it get the food? It steals nutrients from the rest of your body. So that ends up resulting in a cancer patient losing weight, feeling bad, and feeling poorly. Tumors can actually physically cause problems as well. They can obstruct the GI tract. They can make it so that you're not able to eat, that you can't keep any food down. They can attach themselves to muscles or nerves so that you just can't walk. It hurts to walk. It hurts, and it's difficult to do those types of tasks. Most of the focus on reversing sarcopenia focuses on trying to improve exercise and nutrition. I'm not going to go into a lot of the details of that. Dr. Rogers is going to follow me up and talk a lot about that here in just a few minutes. But if these features are inherent to cancer, if they make you sarcopenic, if they make you lose weight, if they make you overall have a functional decline, are we asking too much of our patients to try to reverse those things so that they can improve their outcomes? Is it fair to say you've got to do better with your walking, with your eating? And this is where the next step of research essentially is going to evolve when it comes to sarcopenia, when it comes to functional status. And we don't have a lot of good answers there, but we do have some. So this is a very basic study. This was a study produced just recently with patients with cervical cancer. And what they asked were, could we put patients through an aggressive physical therapy regimen to improve how strong they are? And so before and after an 11-week regimen like this, just like the Pack Health guys described, and these are, these are random measurements of isometric and isotonic power, but they were able to show that by putting them through 11 weeks worth of treatment and therapy like this, you can improve some of these features. Granted, this is cervical cancer, it's not a GI cancer, and so it's not always applicable to everything we do. But we can even go so far as looking at this for breast cancer. So these are patients undergoing chemotherapy for breast cancer. And this was a trial just recently published where they took patients who were sarcopenic, who had decreased muscle mass, and they randomized them to either undergo some sort of aerobic training regimen or a resistance or strength-based training regimen. And what they found were that people who underwent the resistance training regimen were far more likely to reverse their sarcopenia. So roughly 40% of those patients were able to reverse their sarcopenia. That's not a great number, but at least it's something. We're starting to see something that we can go there. By contrast, if you used a more traditional exercise-based regimen using aerobic activity or even supportive care without any special attention to this, only about 10 to 15% of those people were able to reverse their sarcopenia. But the outcome was not just that we reversed their sarcopenia, but the people who had a reversal in their sarcopenia had a much better change in their quality of life. They were happier. They were doing better from their breast cancer and the chemotherapy they were getting from their breast cancer. What we haven't shown yet, unfortunately, is that whether or not we can reverse these trends and whether or not that'll actually improve the way people do from their cancers. So in other words, if we can get the person who's losing weight, who's losing muscle mass, and we put them through an intensive regimen, can we not only reverse their weight loss, can we make them stronger, but can we also make them live better and live longer? We may be able to make them live better, but can we make them live longer? Can we improve how their body is going to then be able to fight their cancer? And that's the next stage in research when it comes to sarcopenia, when it comes to frailty, and when it comes to functional status. And that's where we're trying to move forward next. So will a program that improves participation and completion of disease-specific interventions, so in other words, will it make it more likely to finish your chemotherapy? Will it make it more likely to have fewer surgical complications, in other words? And ultimately, can we make these people live longer and live better with this intervention? So can we improve their nutrition? Can we improve their exercise? And can we make them do better as a whole? So kind of in summary at this point, I know I wanted to catch us back up, so I went a little faster. Frailty is a semi-quantitative entity. It has significant implications for cancer and cancer patients. It can be used to predict the outcomes of patients who have cancer. Sarcopenia is an excellent surrogate for measuring frailty, but it is cumbersome to use in clinical practice. Even it's cumbersome for you at home as well. You know, nobody wants to sit there and time how long it takes them to walk 5 meters or take the little strength and see how much you can squeeze with the stress ball. However, functional status that we've started to describe here at UAB is probably a simple test for sarcopenia and frailty. And it may actually be better than those two tests that we've been talking about thus far. Exercise and dietary modifications can potentially reverse some of the cancer-related frailty things that we see. However, future studies are going to be needed to test how these interventions can help our cancer patients. All right, thanks guys. Do you guys have any questions? Anything y'all want to know? You guys have been very quiet here. Listen to me talk. Listen to me talk about my dad. Poor guy. And I told him, I said, do you really think that all of us look alike? If you can't tell us apart?